Hi guys, Dr. Gillard here. It's cardiovascular pathology. Haven't got to pulmonary pathology yet, but we will. It's Tuesday, it's week 9, spring of 2021. Here we go. Okay, we're going to talk about premature atrial contractions today, or PACs. And oh my gosh, look at all the AKAs. What are we going to do? I don't know. That's your authors out there. They're all over the place with this. I'm just going to call them premature atrial contractions or PACs. Premature atrial complexes are actually the things that you look at on the EKG. The physical contraction of the heart, because of the premature complexes, are premature contractions. So, atrial premature beats is a common one. Atrial ectopic foci are a common one. Premature atrial ectopic foci. Premature atrial depolarizations. So, yep, I would memorize some of those, but the ones in red in particular. They all have the same kind of theme to them. I'm not going to be crazy nitpick on that. If there's a wrong answer, it'll be definitely wrong. A very common phenomenon in the hearts. A few PACs a day are not unreasonable. In fact, the Switzerland study back in it was like 10 years ago or so, studied 1,700 patients, over 1,700 patients. It found 99% of just normal 50-year-olds had at least one premature atrial contraction or complex over a 24-hour Holter monitor period. So 60% of normal adults will have a few of these, according to another research group, of all adults, any age group. So everybody's probably felt a skipped beat in their heart before, or most of you have. What are they? What are PACs? They're ectopic foci. They're areas of cardiomyocardium cells, maybe one cell, maybe a group of cells, that depolarize quicker than the SA node. That's their claim to fame. They beat the SA node, and we've talked about that before, right? We've talked about PJCs, premature junctional complex. It's the same thing. So it means that the ectopic foci has paced the heart. So at least for that heartbeat, this crazy wild ectopic foci has taken over the rhythm of the heart, and that is an arrhythmia, and that's an irregular beat. They, remember we said these junctional ectopic foci can sometimes be the hero or the zero. They can be mischievous, but sometimes they're the hero if your SA node fails. These guys are never the hero. They're not going to pace the heart. That's always the junctional region's job. They're always mischievous when they come. Specifically, they may be a couple a day, a couple an hour, a couple of weeks. You might have a couple. They could be all over the place. They could be every second, or not every second, but every minute. So they could really cause some discomfort in the human. They can also spark some of the supraventricular tachycardias that we are going to look at. Right? Again, just like with PJCs, if you hear them, that's called a palpitation. Or if the patient who has them feels them, that's called a palpitation. And they do not rescue the heart. There's no rescue beats. And that's a common thing I test you on. The junctional region rescues, not the atrial region. What do you do as a chiropractor? What do you do when you discover them? If you're doing a heart exam and you're doing physicals and you hear them. Well, your job is to refer to a cardiologist. What does the cardiologist do? The cardiologist will work up the patient, and he orders something called a Holter monitor. It's a 24-hour recording. You put electrodes on your chest and tape them up, and you run this thing for 24 hours. You have a event button. If you feel them going, then you push the button, so when they look at the recording, they can go back to see what you were feeling. And if for whatever reason, and here's a 24-hour monitor, it's much bigger. It's got more leads, so you can see, you you can have a better look at the arrhythmia when it pops up. What happens a lot of times, though, is these things can be hard to catch. Um, they kind of come out of the blue. So they're paradoxical. They come out of the blue, start out of the blue, stop out of the blue. And so what often happens is if this thing fails to capture them, or you tell the cardiologist, they really didn't bother me that much, then they prescribe a longer acting one. So this is, I've had these before. So this is it's like these newer models are like a gigantic Band-Aid, and you just put this Band-Aid on, and you wear it for 2 weeks, and you can shower with it. It's a pretty amazing thing. It still has an event button right there, and you push on that when you feel the whatever you're feeling, and then they can analyze it. It's all computer analyzed, and they'll give you a reading of what's been going on. As I said, PACs can cause trouble. Sometimes people can't feel them. They have no clue that they even have these things. Other times people can have them. They're completely innocent, but they freak out about them, and they become very anxious over these. I mean, it's kind of a scary thing when your heart starts malfunctioning, even though the doc will tell you these are perfectly normal. They're not. Almost everybody has them. They're nothing to be worried about. Easier said than done, because I've battled these for over 20 years myself, and they can, when they act up, it's hard to deal with these things. So sometimes some anti-anxiety meds might be needed to calm the patient down. There's a good old Xanax there. And as I said before, it can spark some heart arrhythmias, like AVRT and AVNRT, or AVRT. No, both of them. It can spark arrhythmias, especially AVRT, which we'll look at. Not today, but we will look at AVRT, and I'll show you exactly how the premature atrial complex can set off AVRT, atrioventricular reentry tachycardia. What type of arrhythmias could they spark besides AVRT and AVNRT? By the way, this is the most common. AVNRT is the most common supraventricular tachycardia. And that's just the tachycardia where your heart just takes off running and you're not doing anything. It's going. Had a patient today I talked to. He had a supraventricular tachycardia. His heart was going 210 beats per minute according to his Apple Watch for about a week before they could turn the thing off. So it can be, lightheaded and all kinds of problems. So atrial fib, these are the arrhythmias could spark all of these conditions. Atrial fib, atrial flutter, AVRT, AVNRT. It typically, thank goodness, it typically does not spark ventricular tachycardias or ventricular fibrillations. Those are dangerous. These supraventricular tachycardias typically aren't dangerous immediately. I mean, if they go on for years, it can ruin your heart. But usually we're pretty good at, medicine is pretty good at getting the heart back under control with regard to rhythm. Now they can also be a warning sign, so maybe this is a good thing. Somebody who's having a heart attack or has heart ischemia, they have coronary artery disease and the muscle starts dying. That muscle can get very cranky, and it could present as some of these ectopic foci popping up. Same with people who've had a myocardial infarction or are having one, they could feel the palpitations. Hypokalemia, thyroid toxicosis, which is hyperthyroidism, pericarditis, valvular disease, these patients who have these conditions all can also have PACs and other arrhythmias for that matter. What are the risk factors? Exactly the same that we've talked about for PJCs. Stress, lack of sleep, fever, hyperthyroidism, tobacco, caffeine, alcohol, congestions, dextromethorphan. Great, Mucinex is a wonderful decongestant, but I can't take it because it's got dextromethorphan, and it'll make my heart go absolutely cuckoo. Treatment. So what do we do for these? Well, after you get it worked up and they're deemed to be no big deal. Best thing to do is don't do anything. Try to ignore them, learn to live with them if you can. If you absolutely can, and to that end, helping learn to live with them, you can eliminate the risk factors so you don't have to deal with them. Try to find ways to cut your stress, cut your alcohol, caffeine, chocolate. You can use medications though if you can't deal with them. Metropolol is just a marvelous medication. It's really good at keeping these things under control. Works wonderful for me. Better than some of the other medications that I used to try 20 years ago. That my patient who I had today was on, that's what he's on for metropolol for his AVNRT. And it does really good at keeping it in control so it doesn't take off. Treat the anxiety, you might need psychotherapy. You might need Valium. If all else fails and you can't control them and you can't have your heart running 210 beats per minute for very long. It'll wreck the heart, so that's got to be controlled. So if you have what's called a high burden of these PACs, which is 30% of your heart beats are actually palpitations, they will go in and try to search for the ectopic foci and basically zap it, burn it out of there. And it's kind of hit or miss. Sometimes it works. Could make the palpitations worse is one of the risks. But I think it's probably 50-60% chance that they can get it, is what they used to say. But I mean, you got to try something. If you have a burden that high, life is not good. Okay, now let's look at the PAC findings. What does a premature atrial complex look like? We talked about what premature junctional complexes look like. So these can be a little tricky to find, but there's some rules here. First of all, where do they occur? They are going to occur right before the normally scheduled P wave is supposed to occur. So in other words, normally the RR intervals are normal through EKG tracing. So they'll occur prematurely, and that's one of the best ways to spot them. One of the first things you do when you're reading an EKG tracing is look at the rhythm strip and look at the RR intervals to see if they're perfectly evenly placed. If they're not, something's going on, and it's probably some type of ectopic foci, especially these PACs. So look for inconsistency in the RR interval. And then you're going to look at the morphology of the P wave, because PJCs can also mess up the RR interval. But there's definitely a difference between PJCs and PACs when it comes to the P wave. So here's a 26-year-old female who reports with some weird feelings in her chest. They started a week after finals, no sleep, you guys know the deal, lots of caffeine, lots of stress. The first two beats are normal, so these are normal beats. So then we want to look at how fast the heart is going. So that's 300 to 150. Let's just count the boxes. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 boxes. So we have a slow heart rate here. And so I gave you the fact that this is normal. This goes on and on and on through the rhythm strip. But then we see 1, 2, 3, 4, 5, 6. We have one that's occurred way too soon. It shouldn't have occurred till down here. So the RR intervals, you guys know what those are, right? These are the top of the R waves. So these are called the RR intervals. Use the peak of the R waves. So the RR interval it's messed up, right? You have a short RR interval. And yeah, that's a PAC. And then the next thing to do is look at the P wave. Well, let's look at the normal P wave first. Okay, that's a nice P wave with a nice long PR interval here. And look at this P wave. What's the matter with it? It's upside down, isn't it? Well, wait a minute. Didn't we say those are junctional complexes are upside down? No. Well, yeah. But remember, junctional complexes don't have a PR segment, or they have an incredibly short PR segment. If you see this part, it's not coming from the junctional region. So, yeah, so that's a kind of a run-of-the-mill PAC. And then another phenomenon because check this out. So I forgot what we were. Let's count them again. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so let's look when the next one starts. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's supposed to start right here. What happened? So it's delayed. That's another very common thing you see with packs. It takes a while. The SA node got shocked by this premature complex. The electricity hit the SA node. It's not used to being hit and knocked out. It's used to being the king. And so sometimes it doesn't wake up quite quick enough. And so there's a delay here. That's called a compensatory pause. Compensatory pause. So that's another indication that this is a premature beat right here. Right, and I have slides on that coming. I got ahead of my slides though. So more EKG findings. So long or normal PR interval. So yep. So the PR interval and PR, it'll have a PR segment. Remember, PJCs have no PR segment. So it has a long or even it has a normal or even a long PR interval. And it depends. How long is it? It depends where it occurs in the atria. Because if it occurs over, let's say, in the left atria, where that last one probably did, way over to the lateral part of the heart, it takes a long time for that wave of depolarization to spread across the atria. And so you get a longer PR segment or PR interval because of that. There's no superhighways. It doesn't use Bachmann's bundle, at least at first. So therefore it's long. And that's what makes the PR interval and segment longer than normal. It might at least will be normal. Okay, so it uses slow cell-to-cell spread to spread the wave of depolarization across the atria. Got it? Now the caveat is, so it's possible it could be a short PR interval. If the pack occurs right next to the AV node, then it's going to jump right into the AV node. And so it might be a short, but that doesn't happen that often, but there's always seems to be an exception to these rules. All right, where's it located? So this is important. So P waves can be downward like we just saw, and they could also be upward. So this is a very important slide. I guarantee, make a note card. This will be on the test. An upright P wave means the pack is coming from the right atria. Right is right. Let's look at that. Right is upright. Okay, remember that. The left atria, if it's a downward facing P wave, like the ones, if it's like that, then there's the QRS complex. If it's downward facing, it's coming from the left atria. Okay, another note, not quite all this easy. If the pack occurs right next door to the SA node, it can use Bachmann's bundle, and it's really difficult to tell. The compensatory pause might be there, might be one way to tell, but it can be tricky if it occurs right next to the SA node or if it occurs next to the AV node. Okay. What about the QRS complex? Because if you have a P wave, that's going to go through the AV node and you're going to have a ventricular contraction, right? Depolarization and contraction. Are the ventricles affected is what I'm saying. No, they're normal. So you have a normal QRS complex and a normal T wave. They're not affected at all by the PAC. Okay. We said the SA node gets thrown off. It's not used to it's not used to be getting hit by a wave of depolarization and turned off. So the first beat will be delayed, and that's called a compensatory pause. And I already explained that. So here's a 67-year-old who comes into the ER, strange feelings in her chest, made her anxious. She wanted to get checked out. What do you think of this? Look at that. Let me open my water up here. How's the first beat look over there on the left? Yeah, good. That's limb lead 2. Well, that's normal beat. There's a P wave, QRS complex, and a T wave. Looking maybe a hair big, but won't go into that. Okay, let's see how far between, what's our RR interval? 1, 2, 3, 4, 5, about 5. 1, 2, 3, 4, 5, great. 1, 2, 3, 4, 5. So what do we got here? This came too early, didn't it? Yes, it did. It came too early. So that's a premature beat. Let's look at now let's analyze it further. And to confirm it's a PAC, we need to count the timing to the next one. So 1, 2, 3, 4, 5. It should be here at 6. It's late. So this is a compensatory pause. So that definitely indicates this is a PAC, premature atrial complex here. The P wave morphology is different. You can see these kind of notched. We won't get into those, but these P waves are definitely different from this one. Is it upright or downward? It's upright, so right is right, so it's coming from the right atrium. So we have a PAC coming from the right atrium. Got it? See how we do that? Okay, and everything I just explained right there, yep. The diagnosis is that this is a heart arrhythmia, secondary to a premature atrial complex or contraction. All right, so again, study hint. Right is upright. PACs will typically be upright if the ectopic foci is in the right atria. Right is upright. It will be inverted if it's in the left atria. I could probably take that slide out, but I just left it there. Let's do another one of these. 44-year-old male comes into practice with neck pain, anxiety, feels funny movements in his chest or her chest, which started after a long week of finals and celebrating after. It's like an older student, kind of a midlife crisis student. I've been there and done that. When I was 48, I got into medical school, actually. Crazy. Anyway, so what do you think? Well, look at those RR intervals. Whoa, what's going on here? Look at, they're all over the place. This one's different, this one's different, this one's different. These two are about the same. This one's, so we got PACs occurring. So this has got to be a PAC. Look at that weird looking P wave. What part of the atria is it coming from? It's upright. So right is right. It's coming from the right atria. Let's see. Let's look at another one. This is another one here. That's the same morphology. See how the P wave looks about the same as this P wave. So that's coming from the same place. So yeah, that's the story. Okay, you can read everything that we just said. And yeah. PACs. Let's do another one. Asymptomatic 64-year-old's in the office for a pre-employment physical. Wants to work at Target. No heart disease, so what do you think? And I'll tell you, this is normal right here. First beat is normal. All right, so 1, 2, 3, 4, 5.5 is normal. 1, 2, oh, this is way too soon, isn't it? So the RR interval is messed up. Look at the P wave morphology. It's upside down. So that could be a PJC, but no. Why do we know it's not a PJC? Premature junctional complex. Because of this right there. So there is a PR segment. If it's a PJC, there would be no PR segment. It would, it would have been right here. Oh, that was a terrible drawing, but yeah, so P, and let's check the compensatory pause. So it's 1, 2, 3, 4, 5.5. So this should be more than 5.5. 1, 2, 3, 4, 5.5, 6, 6.5. So yeah, that confirms this is a PAC. There's a compensatory pause. See how that works? Yep. They also have bradycardia too. Forgot to mention that, because remember the 13 box rule, or the big box rule. 300, 150, 175 Deacon Jones, I always remember. 60, 50, so it's a little bit higher than 50. And if you do the 1500 box rule, it comes out to 51.7. So they do have a bradycardia as well. All right, why is that up inverted? How come the sky is upside down? What is limb lead 2 looking at? Well, there's limb lead 2 is looking this way. So here is the this was right though, wasn't it? Oh no, it's downward. So this is from the left atria. So this is the left atria. So you see that the signal goes away. And so the P wave is seen by camera 2 as going backwards. And then just by definition, it draws an upside down wave if it sees the signal moving away from it. If you're completely lost, that means you haven't been watching. You have to go back and watch all these lectures so you understand this stuff. 33-year-old comes in, another pre-employment physical. Claims to be in excellent health. Run an EKG. What do you think? Well, first thing you do, look at the RR intervals. Do they look reasonable? So it's no. I mean, I'm not going to count them. You can clearly see this RR interval is short. Now we look at the morphology of the P wave. Oh, geez, that looks pretty similar, doesn't it? Yeah. Remember I said if they start by the SA node, they can look really very similar. But we know this is not a sinus beat here. This is a pack because it came too soon. And just to confirm, it should have a compensatory pause. So let's count this. 1, 2, 3, 4, and just 4 in one box. So 1, 2, 3, 4, 5. 5 in 3 boxes. So it is too long. So this is a compensatory pause, which confirms that this was a PAC, premature atrial complex. See how that works? It's not too bad. Right, so everything I just said, you can read all about it. All right, that's enough with the PACs. We won't get into PVCs because we just don't have time. Let's talk about the supraventricular tachycardias now, which we're going to kind of expand on because we learned about the PJCs, premature junctional complexes. You can have a premature junctional or tachycardia or junctional tachycardia. Just like the PACs, premature atrial complexes, you can have an atrial tachycardia. So that's what we're going to talk about today. The term supraventricular tachycardia, it's kind of an umbrella main category term. It means that the patient has a tachycardia, so his heart rate's going over 100 beats per minute, usually 120 or above. And supraventricular tachycardia means supraventricular means it's supra to the ventricle. It's above the ventricle. So these are all have to do with the atria in some way, or at least the junctional region. By the way, some authors call SVTs, supraventricular tachycardias, they call them atrioventricular nodal reentry tachycardia, and that's an error. You should never call them that because AVNRT is the most common type of supraventricular tachycardia. So, come on, guys. What's the cause? It's an ectopic foci in the junctional region or the atria. But the catch is that ectopic foci is not just setting off one time. It's setting off multiple times, and it's taken over the heart and running the heart over 100 beats per minute. So it's multiple ectopic foci. It could be the same ectopic foci running over and over and over, acting like an SA node, or it could be multiple ectopic foci all over the heart. Again, supraventricular means that this tachycardia starts above the ventricles and above the fibrous skeleton. Prevalence in the population in general is about, of all ages, 0.2% of the population. As you get older, though, that number gets much higher. The duration of these runs of running the heart fast could be for minutes, could be for hours, days, weeks, months. They could even be permanent. Some people live in atrial fibrillation. They can't get the atria to stop. Another AKA for SVT is PSVT because it's paroxysmal. And they call it PSVT because often they do start paroxysmally. They start out of the blue and they end out of the blue. You can never tell when it's going to stop. It just stops for no reason. I have these things and I can guarantee you there's no rhyme nor reason for it starting oftentimes and stopping. It just starts and stops out of the blue. AVRT and AVR NRT, the number 1 and number 2 most common types of SVT, they're notorious for being paroxysmal. All right, what are the general causes of these SVTs then in general? Well, I already told you. It's either a single ectopic foci that is depolarizing over and over and over. It's a super fast depolarizer that's repeatedly depolarizing. It's acting like a super fast SA node. It can also be a gang of ectopic foci taking turns and running the heart. So maybe gang A runs the heart for 3 beats and then it has to rest. And then gang B kicks in and runs the heart for 3 beats and rest. Then there's this concept of reentry that we are going to talk about before the day is out. So reentry circuit could be set up, and I won't even go off into a tangent until I have my drawing to help with that. Reentry circuits are also called circus movements or reentrant circuits or reentrants. It's a vicious racing loop of current, and we'll look at that in a bit. Here are the supraventricular tachycardias. No one should miss this because I'm telling you right now this is going to be on the test. So make a note card, figure out how to memorize these things. You need to know the SVTs because there's going to be 1, maybe 2 questions on this, so you don't want to miss that. Sinus tachycardia we're not going to talk about, but the SA node in a sinus tachycardia, the SA node is the problem. It depolarizes too fast. EAT, ectopic atrial tachycardia, also known as just an atrial tachycardia. That's when a pack runs the heart and goes repeatedly over and over and over again, depolarizes. Atrial flutter, which leads to atrial fibrillation. In atrial flutter, the atria are beating 300 beats per minute. Atrial fibrillation, the atria on average beat 550 beats per minute. You're wondering how come you're not dead? Well, we'll talk about that when we get there. Junctional tachycardias, then AVRT and AVNRT. So these are all arrhythmias. They're all supraventricular tachycardias. Let's start talking about some of them. The junctional tachycardia, we started this whole EKG journey talking about junctional PJCs, premature junctional complex. So now we have a PJC that is repeating over and over and over, quick and quick and quick, and it's running the heart, and that's a junctional tachycardia. Sometimes it's called an accelerated junctional rhythm or a junctional supraventricular tachycardia. The key, your note card should stress this. This is not a good thing. This is often associated with some kind of structural heart disease. People with aortic stenosis can have this. People who've had heart attacks and damaged heart can have this. Or it might be innocent. Grandma and grandpa and or grandpa can't remember if they took their digoxin or not. And they just to be on the safe side, let's take another one. And then it's dinner time. Did I take one? I can't remember. That's the grandma and grandpa should always have a little pill case so they know when they take their meds, especially digoxin. Because digoxin toxicity can cause these junctional tachycardias as well as other arrhythmias. We've talked about that before. So that's iatrogenic. And don't come up and ask me what does iatrogenic mean in the test. That's man-made. All right, so you always, if you catch one of these, you always refer. I mean, if you catch any of these, you refer these to a cardiologist. All right, let's just remember that junctional region. So there it is. There's the right atria here. Left atria is back behind here. And they've kind of stretched it out over here. But this is the junctional region. Fibrous skeleton would run right across here. There's the AV node. This one, they usually have one of these little approach tracks. Some people have a double approach track. So it's just showing a double approach track. But this is the junctional region, the AV node and the approach tracks. This is all the bundle of His. These are the penetrating fibers of the bundle of His. There's the SA node right up there in the atria. All right, so the pathophysiology, you have an enhanced autorhythmicity. I threw that in there. In other words, you have an ectopic foci that's just going over and over and over, and the ectopic foci is somewhere in this junctional region, and it's almost always the AV node in its approach tracks. It's hardly ever the bundle of His. AV node, the cells in this region are much more twitchy and much faster. Remember, the only thing faster than these cells is the SA node. So enhanced autorhythmicity is another way to say an ectopic foci. It means all cells, cardiac cells, are autorhythmic, where they're counting down, they have a depolarization, they want to spark an action potential, so they're all trying to do that, but the SA node overpowers them usually. So a junctional ectopic foci runs the heart, usually about 120 beats per minute. These ectopic foci, unlike these junctional tachycardias, unlike a junctional ectopic foci, they don't do an escape rhythm. These are mischievous. There's no reason for the junctional region to go into it, to depolarize the heart so quickly. You go into it over 100 beats per minute. So they are, like this little kid here, they are mischievous. What causes the enhanced autorhythmicity? So remember we said these are bad dudes. I already said this. Bad dudes. I won't make any political comments. But we said myocardial ischemia, digoxin toxicity, we said that. COPD can cause this because COPD causes cor pulmonale. It ruins the right side of the heart, which makes it twitchy. Myocarditis can make the heart twitchy. It's infection of the heart. An autoimmune attack of the heart, rheumatic carditis, sometimes the heart gets attacked. Electrolyte disturbances, hyperkalemia, hypercalcemia can both make the heart twitchy and prone to depolarize spontaneously. And sometimes we just don't know what it is. All right, what are the EKG findings for this? Well, number one, you're going to have a heart running over 100 beats per minute. Usually it's about 120 beats per minute. The only reason I brought this junctional tachycardia into the discussion is because AV NRT is the most common of these, and these two can look almost identical. It can be, even for experts, it can be difficult for them to tell these apart. Probably the number one way to tell them apart is a junctional tachycardia is slower. It's usually 120 beats per minute. It could go up to 140. AVNRT, it's not uncommon for that to be running 160 beats, 180 beats per minute. But you can have overlap, and if an AVRT is running at 140, it's really hard to tell it apart from a junctional tachycardia. So I would never put these two answers or answer choices because they're so similar. Even AVRT can look similar as well. Don't worry, I'll make it very, I won't confuse you. It'll be very straightforward. The heart's rhythm is normal, so you're not going to see RR interval abnormalities. If you have a tachycardia and you have RR intervals that are irregular, that's usually atrial fibrillation, and we'll get to that. So the QRS complexes are normal. They're narrow. These are all narrow complex. Not all of them, but this is a narrow complex QRS complex tachycardia. So what does narrow mean? That means the QRS complex, the length of it is less than 0.10 seconds. Some authors say 3 little boxes, 0.12 seconds. Okay, so these patients have a narrow complex tachycardia. P wave findings. What do the P waves look like? P waves will be inverted. they're almost always inverted upside down. They don't have to be, but no, they actually do have to be because it's coming from the junction region. So they have to be upside down. They could be right before, just like with PJCs, they could be right before the QRS complex. They could be hidden, invisible, because they're occurring within the QRS complex. They might occur slightly after the QRS complex, and that's where we get into a little bit of trouble, because they can occur right in the S wave, the up limb of the S wave, and make it look kind of weird, slur it. It's called, they can slur the S wave. And so it really depends where the ectopic foci is. The late P wave, as I just said, if it occurs in that up limb of the S wave, it can slur the S wave, or it can notch the F wave and make it look weird, as seen in limb lead 2. If you look in limb lead V1 and V2, which I'm not that concerned about, it can, because everything is upside down in V1, so it looks like there's two R waves in the situation. That's called a pseudo R wave. I think that's getting too deep. Just be happy if you know the slurred. And we'll stick with limb lead 2, so you get a slurring of the up limb of the S wave. All right, and again, AVNRT can do exactly the same thing. It can slur the S wave or notch the S wave. So just to show you what I mean here, let's look at limb lead 2 here. So we haven't studied the QRS complex that much yet, but you can see it's way too wide. It's supposed to fit within 3 little boxes for sure. Some authors say 0.12 seconds, some say 0.10. But this, I mean, this is the S wave, right? Where's the S wave? Once you go below the isoelectric line, that's the S wave. So this S wave is built with 1, 2, 3 waves. It shouldn't be like that, right? This one doesn't help us much because it's not showing us an S wave. So it went back into rhythm. But this is slurred. It's like built with 3 lines. It just looks weird. It looks too fat. Sometimes you actually can see, and this is a drawing too, I think. You can see, I'm exaggerating that, how you can sometimes see like a little notch or a little bulge in here. And that's where the P wave is. And just, I'm not going to test you on this, but in limb lead 1, everything's backwards. But you can see that it looks like there's a R wave here coming after the S wave. So that would be called an R prime. Prime means it's a second R wave, even though there's no, the R wave is upside down. And that's confusing. But, so don't worry about that. All right, let's look at a 38-year-old male comes in. And these are hard to find too, so some of these pictures aren't the greatest. This is a 38-year-old male comes in with anxiety and back pain. Rapid pulse, you perform an EKG. What do you think of this guy? Well, so per our training, the first thing we do is let's look at the RR intervals. Just kind of scanning them. Yeah, they look, I don't see anything crazy. I don't see any irregularity in the RR intervals. How about the speed of this? This one's right on the hash mark here. So there's 300, 150. This is just a hair under 150. It's probably 140, which is a bad place to be because that's both junctional tachycardia and AVNRT. Usually AVNRT runs faster though, right? We said it runs about 180 usually. So, but yeah, so we got a heart rate going 140 beats per minute. Let's look for the P wave. There's the T wave. Where in the heck is the P wave? Yeah, this one's a little hard to see, but I can see it. That's not a straight line. It's bulging a little bit right there. This should be straight up, right? And it's got this little bulge right here. Okay, so that up limb of the S wave is slurred. So that tells us, there's a better one right there. That tells us that it's either a junctional tachycardia or AVNRT. Because it's 140 beats per minute and AVNRT is usually like 180, it's probably a junctional tachycardia. Right? 130, I said it's 100. I guess if you do the 1500 little box rule, it comes out to 130. That helps us. Then it's definitely a junctional tachycardia. Okay, so just another drawing. Again, you have to be able to see how this is not built with straight edges. Again, there's like, oops, let's go over here. This should come straight down, go straight up. Instead, it's got all this extra stuff in it. That's slurring of the S wave. Right, let's do another one. 25-year-old college student comes in complaining of syncope, anxiety, malaise after a hard night of drinking at a frat party. Chest also hurts. What do you think of this? Well, I take some water. I see a couple of things. Well, our intervals look fine. How's the speed? See if we can find one of these on the major hash mark. We can't. So it's one box past the big red line. So that would be 300. It's not 300. That would be 150. It's not 150. This would be 100 here. So it's between 100 and 150. It's probably like 120-ish, I would guess, just by eyeballing it. So let's look for the P wave. Where's the P wave? That's the T wave. I don't think we're going to talk about that. I can't remember. Because that's kind of like a TP. That's weird looking. But here's the P wave. So is that coming from the atria? No, there's no PR segment. So this is a junctional tachycardia. Now see, there's no slurring here. See how short this is? The up limb of the S wave. They're very short together. There's no slurring like that. So it looks like a junctional tachycardia. 125 beats per minute, classic junctional tachycardia from alcoholic toxicity. Too much alcohol makes the heart twitchy in many people, especially when you get older. And yep, there's the P wave right there. 68-year-old comes in the office for a pre-employment physical. You run an EKG. What do you think of this? Limb lead 2. Check the RR intervals. They look pretty good. Where's the P wave? I don't see a P wave. Do you see a P wave? I don't see a P wave. I don't even see an S wave really, which is fine. Then we don't have to worry about slurred S waves. Where is the P wave? P wave is hidden within the QRS complex. So now we just need to know how fast this is going, because it's either junctional tachycardia or it's AVNRT. So we just need to count this. This is fine here. Let's use this one. So let's see, it's one before, so that would be 300. That would be 150. That would be 100. It's closer to 150. It's probably that 140 area again. Still say it's probably a junctional tachycardia, but differential diagnosis if you do the 1500 little box rule, it's also 136. But junctional or AVNRT has to be a differential diagnosis for this. See how that works? Oh, another one we're doing. I thought I took this out. 62-year-old tried to do the Boston Marathon, did the Boston Marathon, came into the ER 4 hours later, stating his heart just won't stop, just racing and racing. Get out the EKG machine, fire it up. Oh my goodness, what do we see here? So this is the full EKG tracing. Where do your eyes go? Your eyes always go down here. This is what I've been showing you. Eyes go down to the rhythm strip. Let's look at the RR intervals. How do they look? It's like 2 boxes there, about 2 boxes, about 2 boxes. Nothing too crazy, but there's a little irregularity in the RR, but not that much. So now let's look for the P wave. Where is the P wave here? Did I blow this up? Yes, I did. Let's look at this. I don't see any P wave here, do you? There's a T wave from the last beat. So I don't see any slurring really. There's the up limb. See, the up limb and the down limb of the S wave are very tight. They're very close together. But you see the problem? We got a big notch right here. So that's notched. What is that? That's actually a late P wave. Okay, so this is a case where the P wave is coming after the QRS complex. And what's the heart rate here in this patient? So one before, that would be 300. This one's going pretty fast. This is about 150, maybe even 160 beats per minute. So this is too fast probably for junctional tachycardia. This looks more like a AVNRT. And yep, everything I said. The heart rate's 150 beats per minute. And it's most likely AVNRT, but a junctional tachycardia can't be ruled out. This one, I could never put these two answers together. See how that works? Oh, another one. I was going to take two of these out, but gave you more practice. 57-year-old comes in, pre-employment physical. No complaints, of course, wants the job. You run a 12-lead EKG. What do you think of this? Where'd your eyes go? Well, always start down here. The rhythm strip is limb lead 2. I know there's limb lead 2 there. That's just a little snippet of that. But we go down here and see what's going on. So I don't see any, the RR intervals look fairly good. Let's blow this up and take a look at limb lead 2. Yeah, see that? Where's the P wave? P wave is right there. Is it going the right way? No, it's upside down. So that's not good. They also have some ticker problems going on because there's not much of a P wave, is there? That could be myocardial ischemia that causes that. We're not going to get into that because that could be all kinds of stuff. But you always worry about myocardial ischemia when you don't see a P wave. So yeah, that's the heart was 115 beats per minute. I forgot to do the heart rate, but yeah, it's coming before here. So junctional tachycardia. I don't think this can be AVNRT. It's just too slow. So this one's a pure junctional tachycardia. All right, what do you do? Where do you send them if you find one of these? I mean, what if you're just auscultating and you hear skip beats, or they come into your office and they have a tachycardia? You send them to the ER. Send them to a cardiologist. If they have a tachycardia, you should send them to the ER. You don't set up an appointment with the cardiologist. If they have a tachycardia, you send them to the ER, and the cardiologist will be there awaiting them. Yeah. Myocarditis, we said there's all kinds of conditions. Ischemia, there's things that might be causing this, right? It could be completely innocent. How do we know they're not having a heart attack? We don't know. That's why you send them to the ER. What's the treatment for junctional tachycardias? You could try to slow down the rate of ventricular contraction with carotid massage. You should definitely not do carotid massage. I don't care if they teach you that at school. I think I took it out to save time, but there's a New England Journal of Medicine, the #1 journal in the world, published an article in 2018, I want to say, about the fact that sometimes carotid massage can stimulate the ventricles to go into overdrive and cause a ventricular fibrillation and kill people. So this should only be done in the hospital setting. So chiropractors should not be doing carotid massage in their office. All right. In the ER, if the carotid massage doesn't work, which is important, you want to do it because you want to try to naturally slow things down so you can get an ultrasound. We'll talk about atrial fibrillation, how important that is. But if that doesn't work, they often have to go to the adenosine. Adenosine is a medication they inject into you and basically stops the heart for a second and lets it reset. It's very scary. I've had patients who have had that done. It's very scary. Feels like they're dead. But they don't die, of course. That's very good at setting the heart back to normal rhythm. And then to keep it in normal rhythm, metoprolol is the beta blocker of choice to keep it in rhythm. For stubborn cases, there are medications, propafenone, satrol combination, and combined with beta blockers or even digoxin, ironically, which is something that can cause these things. If you take this correctly, it's really good at keeping the heart under control. Yeah, and if all else fails, you might have to go in and find who the ectopic focus is and try to zap it. All right, so that's enough of junctional. Let's talk about atrial tachycardia. They like to call this one ectopic atrial tachycardia. I don't know why, but they do like to call it EAT. A strong AKA is atrial tachycardia, but you should call it ectopic atrial tachycardia. A focal atrial tachycardia is another one. There's a bunch of AKAs again, but those are the big AKAs. So a very similar story to what we just said about the junctional tachycardia. And if you know the rules for the atrial premature complexes, they kind of carry over to this thing. But there's one new thing we're going to talk about. So it could be caused by a single ectopic beat going really fast. It could be caused by a gang of ectopic foci. I don't know why I didn't put that in there. I think it's coming later. They're called wandering pacemakers. So it could be caused by a gang of them. And then it could be caused by something we haven't talked about yet. A micro reentry circuit somewhere in the atria. So we need to explain that, and that's pretty high yield stuff. There's macro reentry circuits and there's micro reentry circuits. Let's talk about this micro reentry circuit. And sometimes it's called a circus movement or a circus reentry. It almost always has the word reentry in there somewhere. All right, so let's talk about it. So this is a busy photo, but I didn't want to try to split this up, or busy slide. I want to keep this in the same. I shouldn't have drawn it obliquely. I should have drawn it across, but I don't want to redraw it. So here's the story. So a micro reentry circuit can run the heart really, really fast. And it's almost like a perfect storm. So this whole area, we are in the atrium. And this can happen anywhere in the atrium. Okay, in this cartoon, it looks like we're in the right atrium. All right, here's the AV node. So the dream of every wave of depolarization is to get to the AV node. That's its mission in life. And so the SA node sparks an action potential, and it's sweeping over the atria, and that one of these is heading right for the AV node. But this patient has had a heart attack prior, or maybe they had an infection, maybe they had scarlet fever, maybe they had rheumatic fever. They have a piece of damaged myocardium, and it still works, but it's very slow. If a current gets in here, the current moves like a turtle. Usually the current flies through the myocardium. Cell-to-cell spread is still incredibly fast. Even the current going through here, it can run the heart 200 beats per minute. But compared to this current, which could run the heart 500 beats per minute, it's slow. And the other property of this is it's able to repolarize and reset really quickly, quicker than this tissue out here. And that sets up a perfect storm. If you have a tissue that is slow in conducting the current through it, but is really fast at repolarizing. What's I mean repolarizing? Resetting. It resets and it's ready to accept another action potential to pass it along. You have a perfect storm to set up this phenomenon called micro reentry. And what happens in our story is we'll look at two currents are born from the SA node, and they're zipping along. Current 1 gets into this tissue and it's slowed way down. Current number 2 just goes right around the side of it. It doesn't get in because current 1 went in there. And so current 2 is already in the AV node, while current 1 is still maybe halfway through this thing. So the AV node slows the current down and then lets it go, and the heart goes. The ventricles depolarize. As the ventricles are depolarizing, this current pops out, but it can't, well, maybe it can or it cannot, but it pops out, and usually what happens is this is still in a state of repolarization, so it can't go this way like current number 2 did. So it can only go, it can go in different directions, but it goes backwards like this. This current right, or this tissue right here, is already repolarized and ready to go. This current is not ready to accept, or this tissue is not ready to accept the action potential. So our slow current, we'll call it, goes back up this way, changes directions, because it couldn't go toward the AV node. When it gets to the top of the AV node, or when it gets to the top of the slowed down damaged tissue, remember we said this is a really fast repolarizer, it goes, oh look, I can go in here, and it goes back down this slowdown thing. And this is all before the SA node is still counting down. It's not time to have another action potential. And part of the current goes this way, and another part, the current splits here. Part of it goes into the slowdown portion, and the other part goes back toward the SA node and hits it and knocks it out. So it was counting down, now it has to start all over again. But this time when the current comes out, it's depolarized, and the current, it can accept the current that comes out of here, and it goes right into the AV node. And the same thing happens when it comes out of here, it splits. Part of it goes to the AV node to run the heart, and the other part circles back. Comes through here again, the same thing happens. Hits the AV node again. AV node lets the current go through, and you get a ventricular contraction, but part of it goes back. And so you get this cycle, this where the current splits here and it splits here, and you get this vicious racetrack of current, which can run the heart really, really fast, sometimes over 200 beats per minute. Okay, so it's slow, but it's not that slow. Compared to atrial fibrillation, which runs the heart on an average at 550 beats per minute, this is slow, but it's still, I mean, can run over 200 beats per minute if you have to. So that's a micro reentry circuit. So play that back if you're confused on that. So there's a macro, I took these slides out because we don't have time, but there's a macro reentry circuit. Is the same thing, only it just races, the current races around a much bigger structure. People with atrial flutter usually started by a macro reentry circuit, but we won't talk about that. Okay. So back to EAT now, represents about 15% of all supraventricular tachycardias. It's more common in children than adults, and it typically runs a little faster than junctional tachycardias. So it's an average, we'll say, about 150 beats per minute. But it can still run the heart. I mean, 120 to 180 is what Shu says the average is, but on average about 150 beats per minute. Where does it arise? It can arise in the right or the left atrium, just like a PAC can. But it typically likes the left atrium. So left, is that going to be an upright or downward P wave? Well, let's see, right was upright, so this must be downward. So these are inverted P waves. They will definitely be before the QRS complex though, right? If you want to get into the weeds, it actually, the most common place for the ectopic foci to live are around the pulmonary veins, where the 4 pulmonary veins come into the to the left atrium. That's where these little spontaneous depolarizers like to rear their ugly heads. And yes, the P wave will be inverted. It's typically paroxysmal, could starts and stops out of the blue. These can be sustained though. The ectopic atrial tachycardias can go on indefinitely, and sometimes they can be hard to snuff out, although that's rare. But if you do have one of those, it can ruin your heart. And cardiomyopathy is wrecked heart. That specifically is called a tachycardia-induced cardiomyopathy. Right? Just remember where the pulmonary veins come into the right atria, right there and there. Okay, that's where there's one sparking right there. How about the causes? Well, really the same causes we've been talking about, maybe a couple different ones. Iatrogenic, digoxin, Catecholamines, we talked about pheochromocytomas before. These can present with EAT, ectopic atrial tachycardias. People with these rare pheochromocytomas can do that. Atrial scarring from a previous myocardial infarction or an infection can, in this case, these two both cause that slowdown region and cause that reentry loop that goes. And then idiopathic, sometimes they just happen and we don't know what the deal is. EKG findings. So this is important. So the ratio of P waves to QRS complexes will be 1:1. So for every P wave, you will see a QRS complex. And the reason I say that is because when we talk about atrial fibrillation, that's not the case. And even atrial flutter, that's not the case. There's way more atrial, there's way more P waves than there are QRS complexes. In fact, there's so many P waves that you can't even see the P waves anymore. The RR intervals will be the same. That's not true of atrial fibrillation, or that's not true of atrial fibrillation. You have irregularly irregular RR intervals. But with EAT, they're the same. RR intervals are the same. With junctional tachycardia, RR intervals are the same. Just like junctional tachycardia, you'll have a narrow complex tachycardia, meaning the QRS complex is normal. It's less than 0.10 or at least 0.12. The P wave is typically inverted, we said, because this likes to start in the left atrium down by the entry to the pulmonary veins. P wave will never be hidden by the QRS complex. If it's hidden, then it's a junctional tachycardia. So for EAT, it's never hidden. PR interval will be normal or slightly longer than normal. Yeah, because sometimes it has to travel a ways. So there will definitely be a PR interval there, unlike junctional tachycardia, where you won't even see a PR interval. All right, let's do a case study. 52-year-old female comes in, palpitation, anxiety, presyncope after 3 nights of binge drinking. She thought she was 20. Now she's miserable. Do an EKG. What do you think? Limb lead 2. Okay. RR intervals. That 3 dots means it goes on forever. I don't see anything crazy. What is the heart rate here? This one is right on the hash marks here. So there, that would be if the other RR wave would be right here. That would be 300, 150, 100. So it's like 120-ish or so. And now let's look at the P wave. P wave's upside down. Now the question is there a PR segment? Absolutely, there's a PR segment. So this is a atrial tachycardia, an ectopic atrial tachycardia. See how that works. Yep, everything I just said. You can read about it again. Right, there's a cartoon of it. Maybe that's the ectopic foci here. That's why the camera makes it upside down, because the waves are going away from. We've already talked about that. Let's do another one. 69-year-old female comes in, complaining of dyspnea, weird feelings in her chest, hasn't been sleeping. She sadly lost her husband of many years. Did an EKG. This is what you found. Well, let's see. RR intervals look pretty good. How about, what's the speed of this thing? 300, 150, 100. So it's like 120-ish or so. So definitely tachycardia. I don't like the looks of that particularly. That's called a peaked T wave. It's like a tent, but that's not what we're talking about. Where's the P wave? It's upside down. Is there a PR segment? No, I don't see any PR segment. So this most likely is a what? It's a junctional tachycardia, right? Now you got to rule out AVRT. It's a little slow for AVRT, but that's always a differential diagnosis. Do you see another problem? We haven't talked about this, but the P waves are supposed to be round. They're not supposed to be peaked like that. So that is a peaked T wave, and that always makes you nervous. It turned out this patient has kidney failure, and she's supposed to have dialysis to get the potassium out of her blood, amongst other things. And she missed 3 appointments because of her partying and craziness. And therefore, she has hyperkalemia. Her potassium levels have built up, and high levels of potassium in the blood, hyperkalemia, can cause the T wave to look like that. It's called a peaked T wave. The reason it's scary is because it can also look exactly like something called a hyperacute T wave. Guarantee you there's a test question coming on this. This is a hyperacute T wave, it could be. And that's one of the very first findings, even before the Q wave change. This is one of the very first findings in a myocardial infarction. So hyperacute T wave. So it raises an eyebrow. Now, if she doesn't have any chest pain, it's probably okay. Let me show you the difference. Here's another patient. These are V2 and V3, the limb leads. But let's look at this patient with kidney failure from hyperkalemia. You can see the T wave is very tall. Here's the QRS complex. And the T wave is peaked and very tall. And here's someone with a pre-MRI or pre-myocardial infarction. Just before, this is a STEMI myocardial infarction. It's before you get an elevated ST segment. And look at here in V2. Look at how big. It's actually bigger than the QRS complex. And it's peak. So that's a hyperacute T wave. V3 is more like a normal limb lead too. The QRS complex is back to normal, but it's still way too tall, isn't it? All right, so those are 2 things that can cause peaked or pointed T waves. One is a pre-heart attack, it's called hyperacute T wave, and the other is from kidney failure. All right, so I should have included this up as another cause of atrial tachycardia. So there is a multifocal atrial tachycardia, and that occurs when different regions of the atria take turns running the heart really fast. And so this creates, I kind of put it in its own spot because this and atrial fibrillation are the only 2 things that do this. It causes a regularly irregular PR interval. So PR intervals, or RR interval, sorry, irregularly irregular RR interval. RR intervals, when they're irregular, they usually have a pattern to them if you have PVs or PACs. But they can be all over the place. And when you see them all over, different sizes and different shapes of them, it's called irregularly irregular. Atrial fibrillation presents like this, and so does multifocal atrial tachycardia. So this is why I put it in its own area, because it's kind of its own animal. So we're not going to go crazy into this, but check out this 65-year-old comes into your office, racing heart that won't stop. You run a 12-lead EKG, what do you think? It's all over the place. Right? Look at this stuff. There's one notched here. There's a P wave. There's a P wave there. There's many different morphologies in this thing. And then if you go and count these, here's a really long one. Here's a short one. Here's a medium one. There's a kind of short one. Look, every one of these intervals is different. And there's many different things going on here. So this is multifocal atrial tachycardia. And yeah, so that's a crazy one. I think that's all I'll say about that. The P wave has many different morphologies. A junctional region is also involved because if it's atrial, we'll never see late ones like this. This is late. You can see it notched right here. This time it notched in the R wave. Right, so that's a weird looking multifocal atrial tachycardia. Okay, what's the tachycardia rule? Anytime you have a tachycardia on EKG, consider it atrial origin. Consider to eat if these conditions are met. The P waves are inverted, and there is a PR interval that is normal or even longer than normal, and then the atrioventricular conduction is 1:1, meaning for every P wave there is a QRS complex. All right, that's enough for your brains to reabsorb. So some kind of tough stuff. See you next week, and we'll keep going with this. Hi guys, Dr. Gillard. It is CVPP. It's Thursday. It's week 9. It's the spring of 2021. We'll continue our discussion with different arrhythmias and how they present on ECG. Big one, atrial fibrillation. Super common problem. You can see all the commercials on this. So anytime there's lots of commercials, a lot of people have these problems. It is surprisingly a very common condition, especially in old people. It is a member of the supraventricular tachycardia family, and as the word says, atrial fibrillation occurs when the atria go incredibly fast. And it is a potentially fatal condition, as we'll look at in a bit. Those affected are typically on, they should be on anticoagulation therapy. We'll get to that too. So what's the danger of atrial fibrillation? It is kind of indirectly the cause, the number one cause of disabling or even fatal stroke. If you have atrial fib, you have a 5-fold risk for having a stroke. That's why it's dangerous. And that's because the left atria is beating so fast. How fast does the left atria beat? Because remember, the left atria, there's atrial systole, right? And then there's a ventricular systole. The atria beat surprisingly about 550 beats per minute. So basically there is no atrial systole. The atrial is just quivering, which is going to cause problems. We'll talk about cardiac output in a bit. But if the atria is quivering and the blood flow isn't very good in the atria, it's a breeding ground for thrombus, arterial thrombus formation. And arterial thrombi can go up into the brain and cause a stroke and kill you. So it's the emboli from this that kill you. It's not in and of itself, the atrial fib won't kill you, although it can wear out your heart with the passage of time. But it's the big danger is the formation of these arterial blood clots. So yeah, it's a significant increase in mortality, and even non-associated, all types of cardiovascular disease. People who have AFib have an increased risk for all disease, including atherosclerosis, clogging of the arteries. So just not the greatest thing in the world to have. Is it hereditary? There is some evidence that it is hereditary and can be passed down to your kids through mutated genes, which we won't get into. The epidemiology continued, super common. About 2% of the population over 65 have AFib. That's a pretty big number. 9% of people over 65 had AFib. I thought I saw almost 20% of people over 85 have AFib. Don't quote me on that, though. I read something this morning. I can't quite be sure. It's super common, though. People over 65, almost 10% over 65 have this problem. And it has been increasing. We're not exactly sure why that is. The lifetime risk is 25%. That's crazy. African Americans tend to be less affected compared to people of European descent. Females are more affected than males. There's two main causes of atrial fib. It's either a gang of ectopic foci spontaneously discharging, which can be scattered throughout the right and left atria, and they're all beating the SA node to the punch and going very fast. Or it could be a gang of reentrant circuits. Remember we talked about that last time, about micro reentry circuits. So from a previous myocardial infarction, maybe that could be going. And maybe a combination of these two could be doing it. Here's just a gang of, there's the AV node just getting bombarded by signals. These are all ectopic foci going. Maybe one of them is micro reentry circuit, all throwing action potentials, all throwing waves of depolarization at the AV node. And yes, so there are other conditions. We talked about atrial tachycardia or ectopic atrial tachycardia. I cut out atrial flutter because I just don't have time for all this. But these conditions commonly evolve into atrial fibrillation. So you start out with atrial tachycardia for a couple hours, then all of a sudden it worsens into atrial fibrillation. So that's not uncommon. We'll look at more statistics on that. Again, how fast do the atria run? On average, 550 beats per minute, up to 700 beats per minute. So the atria is like a quivering bowl of jello. What are the causes? There's a whole bunch of causes or risk factors with regard to atrial fibrillation. The big three are probably these. Hypertrophic cardiomyopathy. That's basically the heart has been worn out from hypertension, from fighting against afterload for many, many years. And then we have ischemic cardiomyopathy, where you have atherosclerosis clogging up the coronary arteries. And those are the two big ones, I would say. The other ones aren't in any particular order. Restrictive cardiomyopathy is rare. That's amyloidosis, and that makes tissue very thick and non-functioning, and that can cause it. Myocardial infarction, in fact, that's the most common tachycardia seen in patients. Most common cause of atrial tachycardia seen in somebody with a myocardial infarction, and that can progress into atrial fibrillation. In fact, about 60 in patients over 65, the incidence is about 22%. This is for atrial fib in myocardial infarction, so that's another common one. Hyperthyroidism is another fairly common one. That's seen in about 13% of patients who have hyperthyroidism also have atrial fib, battles with atrial fibrillation. What is it about hyperthyroidism? It's actually about T3. Remember, the thyroid mainly produces T4, which is converted to T3. It's actually T3 that soaks into the myocardial cells and makes them really irritable and twitchy, and they're able to depolarize super fast, faster than the SA node. Status post coronary bypass surgery, about 27%. Patients end up with AFib and they don't know what that's about. Is that just from damaging the myocardia and making areas irritable? Not exactly sure the mechanism on that. Some other associations or causes. People with pulmonary hypertension have a high risk for developing atrial fibrillation. And you could say pulmonary hypertension causes right atrial enlargement. You're going to have pulmonary. Well, I guess you could technically have tricuspid stenosis. That I should take that out on slide 14 because that's upstream from the lungs. So tricuspid stenosis would cause atrial hypertension. So anything that causes right atrial enlargement is also a risk factor for the development of atrial fibrillation and atrial flutter for that matter. Left heart failure can cause pulmonary hypertension. Atrial septal defect can cause pulmonary hypertension. COPD can cause pulmonary hypertension. The only oddball here is tricuspid stenosis. I could add pulmonic valve stenosis as well because those are upstream from the lungs. So I need to fix that, slide 14. Wolff-Parkinson-White syndrome, which we'll get to. 20% of WPW patients also have atrial fib. That one they usually get something called AVRT, and that can degenerate into atrial fibrillation as well. Kind of an end of the road, right? These supraventricular tachycardias can all sometimes go to the worst possible type of tachycardia, and that's atrial fibrillation. Some more causes. So acute conditions have to be thought about. Acute pulmonary embolism or a pericarditis can also cause the heart to get twitchy, the atria to get twitchy and go into a fibrillation. So you have to work these conditions up in patients who have brand new. De novo means new. Atrial fibrillation. Some more causes. Sleep apnea is that's kind of the buzzword lately the last 10 years. There's a lot of research on sleep apnea and how much trouble that's causing with people. And atrial fib, it increases the risk of AFib as well. Holiday heart is a very common cause of AFib. That's just drinking too much. It's well known, and I've talked about this over and over. Alcohol makes the heart. Not while you're drinking it, but it's usually the next day or the day after, or even the day after that. But it makes the heart depolarize really easily, makes the atria very twitchy, and the ventricles for that matter. So if you have heart problems, you definitely should not be a drinker. Valvular disease, hypokalemia, hypomagnesia, pericardial disease, acid-base disturbances, pheochromocytoma are all causes as well. Not too excited about this slide, am I? So I wouldn't bother memorizing that slide. What about the sequelae of atrial fibrillation? It's not good for people who have uncontrolled atrial fibrillation. And when I mean uncontrolled, I'm really talking about uncontrolled ventricular contraction. If you can slow down the ventricles, you can live a long life with sustained atrial fibrillation, but you have to control the rate of ventricular contraction. The rate of atrial contraction isn't as important. So that's what I mean by not well controlled atrial fibrillation, where your ventricles are getting up into the 180s, 200 beats per minute, even 150 beats per minute. You got to control that rate of ventricular contraction by all means necessary, because you can wreck your heart. You can, if your ventricles are running too fast all the time, you're not getting a good ejection fraction, and the blood won't have. There'll be a decrease in blood volume, and the coronary arteries can be affected, and they can get cheated out of blood, and your heart tissue can starting to die off. It can become ischemic. Arterial embolisms are also a big problem as well. That's definitely a sequelae. All right, let's get into the EKG findings of atrial fibrillation. So the keyword, make a note card, atrial fibrillation, EKG findings. The first, number one, irregularly irregular. Or it should be regularly irregular, because the RR intervals are irregularly irregular. Does that make sense? I can't remember if that's regularly irregular. The bottom line with this is that the RR intervals are all over the place. Normally RR intervals are evenly spaced out, and we talked about how PJCs and PACs can kind of cause a blip. One or two RR intervals will be messed up. Every single RR interval is basically messed up in AFib. So I think it is irregularly irregular. I'll have to check that. All right, wandering pacemaker. We talked a little bit about that with regard to PACs. Wandering atrial pacemaker can cause P waves with different morphology in the PACs all over the heart. Very difficult to treat that. But those can degenerate into a tachycardia, where you can have multiple, and I mean that's what AFib is, right? You can have multiple PVC or PACs running the heart, and maybe not yet to the point it's a tachycardia, but multifocal atrial tachycardia can progress from a wandering atrial ectopic pacemaker. So we should talk about multifocal atrial tachycardia. So multifocal means there's multiple foci of fast depolarizers that are causing the heart to run over 100 beats per minute. These are classically seen in two groups of people. People with COPD and or congestive heart failure typically get multifocal atrial tachycardia, and it commonly evolves into atrial fibrillation. It's easy to see the difference between atrial fib and multifocal atrial tachycardia because in multifocal atrial tachycardia, or just MAT we could call it, you can see the P waves and you look at the different morphology. In atrial fibrillation, you can't see the P waves. Let's do an example. 65-year-old comes in to your office with neck pain and a racing heart that won't stop. You run a 12-lead EKG. What do you think of Mrs. Jones here? Let me open my water while you take a look at that. Well, the squiggly line, they don't have AFib, for those of you who know AFib. That's just motion. The technologist didn't set the EKG up right. And you often get those little squiggly lines there. But the point is the P waves. Look at these P waves. There's a gigantic upright P wave. The very next beat, there's another upright P wave, but it's not as big. The next beat, we have a downward P wave coming from the left atria. And then we have another bigger down, kind of weirder shaped downward P wave, also coming from the right ventricle, or from the left ventricle. Right is upright, right? These are from the right. Right is upright. Those are right, and these are left. Can you see where there's two in a row from the exact same foci? Yeah, right here. That's the same as that. So that was the same ectopic foci causing that upright P wave. Right is upright from the right atria. See how that works? And yep, there's everything I just said, so you can read about it. Okay, so more EKG findings. So the hallmark is the absence of a P wave. In people with atrial fibrillation, you can't see P waves. They're just replaced by a squiggly line, if you can even see that. They call those F waves, so squiggly lines, F waves. No, just a technical point. You should use the lowercase f for these. The uppercase F is reserved for flutter waves. And again, you can see that on YouTube. I have a video on atrial flutter there, but I'm not going to test you on it. Some more EKG findings for AFib. There's no isoelectric line. The pattern is irregularly irregular. I guess that is the way to go. QR segments are typically normal, so less than 0.12. Or I mean, some authors use 0.12 for the QRS duration. Others use 0.10. Probably should change this to make it easier. That's 3 boxes, right? So the QRS complex should be less than 3 little boxes, which is normal. Some of the fibrillatory waves can mimic P waves, so it can look like P waves sometimes, as we'll see here in a second. The ventricles typically run about 130, 140 beats per minute. There's the range. What's the difference between AFib, junctional tachycardia, which we've studied, premature junctional complexes, which we've studied, versus atrial tachycardia, or EAT? Ectopic atrial tachycardia. We've studied all those. How do you tell atrial fib apart? Well, junctional tachycardias, they will not have any irregular RR intervals. The RR intervals are steady on that one. Premature junctional complexes, they may have irregular RR intervals, but it's not a tachycardia, so that one's easy to get rid of, to cross out. And with EAT, or atrial tachycardia, you can see the P waves and the isoelectric line. You can't see the P waves or isoelectric line with AFib. There's 2 types of AFib. There's fine AFib and there's coarse AFib. Fine AFib, the P waves and the fibrillatory waves are so fine that you can barely see them at all. Coarse AFib is easier to see. The amplitude is greater than 1 little box usually on these. And you could say there's 3 patterns because you can have a mix of these patterns. And here's the classic kind of deal, what they look like. Let's do coarse AFib. So bigger, look at all these squiggly lines here. It's like a child's been scribbling here. So where's the P wave? Where's the T wave? You can't make any of that out. So that's coarse AFib. A fine AFib is difficult to see. We can see it right there, We can see it there, but it can look like a kind of a man-made artifact from not hooking up the EKG leads correctly. So it can be difficult to see. Here's a mix of it. All right, let's go through some examples so you can learn. And I'll tell you, I haven't said this yet, but one thing on when you're looking for atrial fibrillation, you have to look in every single one of your leads, because in some leads you don't see it. Like in this lead, you don't see it so good in limb lead 3, where in limb lead AVR you can really see the squiggly lines right there. And this is a 52-year-old smoker in for a pre-employment physical. And let's always look at the rhythm strip first. I can clearly see squiggly line go in here. So yeah, what do you think? That's fine AFib. Those squiggly lines are less than one little box in height. I know it's kind of hard to see, but this is fine AFib. Anybody, what about the mean electrical axis on this? Let's do an MEA question. Where's the axis of the ventricles? Remember, if I say where's the axis of the heart, if I don't tell you where's the between atria and ventricle, because there's a mean electrical axis for the atria and a mean electrical axis for the ventricles. What if I don't tell you? Then you assume we're talking about the ventricular mean electrical axis. Well, let's see. So who's biphasic in the limb leads? Limb lead 2 is pretty darn biphasic, isn't it? In fact, it's almost perfectly, so this is an easy one, it's almost perfectly biphasic. So, and then I'm just kind of looking ahead at, is the up limb bigger or is the down limb bigger? The up limb is pretty even. Maybe it's bigger in this one. Maybe it's smaller in this one. Looks about even in this one. Looks about even. So this one is pretty much going perfectly perpendicular to limb lead 2. So this is an easy one to draw, right? So here's our camera. Limb lead 2 is its angle of orientation looks right down the 60-degree mark. And then we know AVL is exactly 90 degrees away. So we know the current is either going that way or that way. And so this patient's either got left ventricular hypertrophy or right ventricular hypertrophy, because we also know the normal mean electrical axis of the ventricle should fall in this range, and it's not. It's not even close. So it all depends what AVL looks like. If AVL is mostly positive, then the current is heading that way. So let's go look and see. Where's AVL? Oh yeah, it's super positive, right? So the current is heading there. So this is a left axis shift. Patient has a left axis shift. All right, probably from left ventricular hypertrophy. Although, did we say AFib can also shift it, so maybe that's not fair. But anyway, that was good practice. Yep. Sorry thing. Oh, this is another one. 43 comes in to your office with shortness of breath. You run an EKG. Wife says he's got sleep apnea, snores a lot. Yeah, doesn't mean that much. So is that a T wave? Where's the P wave? What in the heck is that? What's that? So, I mean, if you just looked at this, if you only looked at this beat of the heart, that's why you got to look at more than one beat. You'd say, well, we got an upside down. That looks like a upside down P wave. It's got a PR segment here, so it must be it must be a PAC, premature atrial contraction, coming from the left side, the left atria. But then, I mean, this looks weird. And then we look over this one, it's completely different. And then what is all this stuff? And then what is that? So these are big swings here. These are fibrillatory waves. So this is coarse atrial fibrillation. Coarse atrial fibrillation. All right. Yeah, it can be tough, as I said. It can be tough sometimes to find this. You have to look at all your leads. You might only see it in one lead or two lead. Which leads are the best ones to look at if you're looking for AFib? That's a tough kind of question, but I can answer. I've asked that before. The inferior leads. Who are the inferior leads? The ones down at the bottom, limb lead 3, AVF, limb lead 2, are all kind of looking at the inferior part of the heart. And then the precordial, the right precordial leads, which is only V1, those are all good at looking for atrial fib. Let's do another one. 55-year-old with chronic hypertension comes into the office, mild dyspnea, syncope. What do you think of this? Well, this one looks pretty easy, doesn't it? You can see there's no rhythm strip. I cut that out. But limb lead 3, you can see the squiggly line, right? So it looks like fine AFib. But look at limb lead 2. See what I mean? You have to look at all the leads. You don't see it in limb lead 2. You can see it a little bit in AVF. These downward leads. AVF and limb lead 3 are probably the most inferior. A little strange you don't see it there, but so look at all your leads, the bottom line, and you can see, yeah, the heart rate's cranking right along. How's the axis on this one? Let's look at the axis. Let's see, who is, AVF, almost perfectly biphasic, right? So we could draw our little MEA wheel or a little AOO wheel. We can do this one real quick right here. Using AVF, F to the floor, that's kind of the peeper, the one looking straight up. There's AVF. And if we draw our line perpendicular, it's either like this or like this. So do we know a limb lead over here, right at this area? Yeah, limb lead 1. It's mostly positive, so the current is going this way. This is slightly more negative, right? So it might be going just a hair that way. So it could be going just a hair, because that one's definitely negative. That one looks about the same. This one looks, I mean, it's very close to being normal. It might be just a hair left ventricular hypertrophy, just a hair of an axis shift there. I wouldn't give you one that's that close, unless I, put the answer choices far apart. Yep, so that's fine AFib. All right, what about the ventricular spot? If the atria are beating 500 beats per minute, how come you're not dead? Well, because of your AV node. Thank goodness for your AV node. And the slowdown portion of the AV node slows things down. Remember decremental conduction. The AV node is able to perform decremental conduction, which basically stops the wave of depolarization for a second to give the atria time to contract and fill up the ventricles. If your atria are running 550 beats per minute, your AV node, your bundle of His can help. It has some decremental conduction as well. Typically can run maybe 150, 60, 70, but they can run fast in some people. So, yeah. What do we need to say about the ventricular spots? Yeah, they're all over the place because of the irregularly irregular beats. So the heart rates vary between 100 and 200 beats per minute. Do you need to slow these down? Yes, we already talked about the importance of slowing that down. Absolutely, because it'll damage the heart. And let's get into that a little bit more. It causes causes a cardiomyopathy. It wrecks your heart. But specifically, it's called a arrhythmia-induced cardiomyopathy. And it's not just AFib, it's PVCs, premature ventricular contractions. I have a video on that. We're not going to have time to look at those. But there's the same principle as PACs and PJCs. But yeah, it's if the ventricles are always underfilling, because there's basically no atrial systole, so you're always going to have a decreased cardiac output. And that's enough to do some things. You're going to have a little decreased flow through the coronary arteries, so the coronary musculature, especially in the atria, is going to be cheated out of blood. And it's not going to happen immediately, but with time, the chronic loss of oxygen will damage the heart to the point it starts killing off heart cells, and that's called it ultimately causes ischemic cardiomyopathy. That's a big category. There's other things that cause ischemic cardiomyopathy. One of them is arrhythmia-induced cardiomyopathy. So ischemic cardiomyopathy couldn't be caused by arrhythmic-induced cardiomyopathy, and that's caused by anything: ectopic atrial tachycardias, atrial flutter, atrial fibrillation, AVRT, AVNRT, anything that causes the ventricles to beat too fast for too long can induce and damage the heart. Well, what about the R2A system? Yeah, if you have a decreased cardiac output because you're not filling the ventricles each time, you're going to start to get a release of renin. I mean, the heart can speed up to compensate a little bit, but it can't do that forever. And you're going to get a release of renin to try to correct the blood pressure problem. And we all know the dangers of having too much renin released. It causes too much angiotensin II and too much aldosterone to be released, and we already know how damaging they are for the heart and for blood vessels. In fact, there's some evidence that the increased angiotensin II and aldosterone can cause atrial fibrillation from a remodeling of the conduction system, and it makes the cells twitchy, makes the atrial cells depolarize too fast or want to depolarize too fast. Atrial fibrillation classic symptoms, and all of these symptoms are because you have decreased cardiac output and a little hypoxia. Not enough hypoxia that'll make your lips blue at first, but you will have decreased cardiac output and you don't feel good. You have malaise. You have some dyspnea on exertion going up the stairs. Maybe you feel a little dizzy when you stand up fast. You could have some chest pain, malaise. We said that, confusion, anxiety, and if this has been going a long time, you can become pyloric, and you can get nail clubbing going on. Some of these patients are asymptomatic and don't have any signs, and that can be kind of maybe the only signs they would have is all these other ones, and they don't know why, because you don't feel anything in your chest. Any relationship between ventricular fibrillation, that's fatal, right? We see that in the TV. They bring out the pads, the crash cart. You're going to die if you're going to ventricular fibrillation. Thank goodness there's not much of a relationship between ventricular fibrillation and atrial fibrillation. Very, very rarely in diseased hearts it could involve, but you could get an AFib and then the patient gets atrial fibrillation and dies, but that's not the norm. What about stopping atrial fibrillation? What can we do? Again, chiropractors should not be doing this in their office. This is what emergency room, unless you're an EMT and you have resuscitation equipment in your office, you shouldn't be doing this. Send them to the ER where they could handle if something goes wrong and they go into a ventricular tachycardia or fibrillation. But anyway, let's talk about it. If you stimulate the parasympathetic system, there's a chance you could slow down the rate of ventricular contraction. That's the whole name of the game. That's the trouble, is when the ventricles are contracting too fast. So you could try, in the emergency room, you could try to stimulate the parasympathetic nervous system in various ways, and we'll look at those here in a second. There are maneuvers, and all of these maneuvers increase the parasympathetic flow to the heart, which increases decremental conduction. If you increase decremental conduction, not all of those impulses will get to the ventricles, and it'll decrease the rate of ventricular contraction. So what are the vagal maneuvers? The parasympathetic is the vagus, right? So unilateral carotid massage is classic one. If you stimulate the carotid sinus, which is located right by the laryngeal prominens, the Adam's apple there, if you push on that and rub on that thing for 20 seconds, it sends increased flow into the tiger cage, into the vasomotor center. And so that will shut the tire cage door tighter and sympathetic outflow decreases. It doesn't do anything to stimulate parasympathetics, but if you decrease sympathetics, then parasympathetics are going to rule, and that will stimulate decremental conduction, slow the heart down. Valsalva's maneuvers are thought to do the same thing via the nerve of Herring. That'll decrease sympathetic outflow, which automatically means there's more parasympathetic influence on the heart. The gag reflex is interesting, also called the pharyngeal reflex. If you take a tongue depressor and rub the back of the oropharynx, well, it's going to make you gag. But how does that, what's the mechanism there? Remember, cranial nerve 9 carries afferent signals into the medulla. And there are some adjacent nuclei next to that nuclei where afferents come in from cranial nerve number 9. And it's thought that they stimulate the neighboring nuclei. And one of those is the vagal efferent nuclei. And so with a gag reflex, you're stimulating the vagus nerve directly, or not really directly, because I mean this is a cranial nerve 9 that's coming in, but its nuclei is right next door to the vagal nuclei, so you're getting a little spillover is the thought there. And if you stimulate the efferent vagal nuclei, it's going to stimulate the AV node. A diving reflex is another one it's called, where you hold your breath and rub your face with ice cubes. That stimulates the trigeminal nerve. Same kind of deal. It ends up stimulating the nuclei in the hypothalamus of the vagus nerve. If all of that doesn't work, then you have to go to adenosine. We've talked about that before. That has the potential to flat out, not just slow, that has the potential to stop atrial fibrillation, kind of resets the heart. It's about 90% effective. It hyperpolarizes the cardiac membranes, so they can't depolarize for a short time. And it kind of simulates a really slow bradycardia, or even a temporary cardiac arrest. Remember I said that I had a patient who went through that, and it's kind of a death experience. It's contraindicated in Wolff-Parkinson-White patients. It could actually kill someone with Wolff-Parkinson-White syndrome, so we will be looking at that. Actually, we'll look at that in a little while. If all else fails, you can use a calcium channel blocker. Verapamil is one that comes to mind here, and also good with AVRT and AVNRT that is resistant to adenosine. If that doesn't work, if adenosine or the calcium channel blockers don't work, then you have to bring out the paddles, and you don't go right to defibrillation. You start with electrocardioversion synchronous current. It's low energy, it's easy to tolerate, you're not going to jump off the table like you see in the movies. But if that doesn't work, then you're going to go to unsynchronous current. That's defibrillation or unsynchronous cardioversion. And that is a high energy form, and you will jump off the table. You'll contract all your intercostal muscles, and you'll that's a pretty traumatic one, but that's the last result. What about stroke? So I left this in here. Garcia still talks about this, about the importance of trying to slow down the heart via the vagal maneuvers first. If you can slow down the heart, you can get an ultrasound or a MRI or a CT. Probably an ultrasound's best. But why would you want to do an ultrasound in these patients before you do cardioversion, especially that asynchronous one? Well, they might have thrombus formation in the atria, right? Thrombus formation in the atria is no good. If you jolt them with asynchronous or even synchronous current, you could jar loose a chunk of thrombus and cause an embolism. It could go up into the brain and cause a stroke, and that does happen to patients. So it's always good if you could try to slow down the heart so you can get an ultrasound. What about controlling atrial fib? Can you even control it? Yeah, after you have it stopped under control, there are mechanisms. You can use potassium channel blockers, digoxin, metoprolol is a beta blocker. You can use all these, and you should be all these to prevent it from coming back. And my patient, he's on metoprolol, and knock on wood, he hasn't had a AFib attack for quite some time. Calcium channel blockers you can also use. The types of atrial fib, there are two main types. There's paroxysmal atrial fib. That's an atrial fib that has started and it's been going for less than 7 days. If it goes over 7 days, and this is whether they try to treat it or not, maybe you go to the ER and you treat it, you go home and it starts back up again. If it goes longer than, or 7 days or longer, I should have put a 7 days or longer there. Some authors call that long-standing persistent AFib. And then there's the type of AFib that's, or the long-standing mean it's been there for more than 1 year. And then there's permanent AFib, where you've had this thing for a couple of years and you've been to all sorts of heart specialists and they can't stop it. That's permanent AFib. And so permanent AFib, you have a much greater risk for developing stroke and dying from that, or heart damage, compared to paroxysmal. If this kicks up, you went out and drank too much and it kicks up for 3 or 4 days and it stops and you have to go to the ER, but that was effective at stopping it. It's not nearly as dangerous as someone who's in AFib all the time. And persistent AFib is difficult to treat. You can try, that means you've tried adenosine, you've tried calcium channel blockers, you've tried everything. So then you can try to find the ectopic foci and ablate it and zap it and get rid of it. But usually there's too many of them and they're coming from too many places and you just can't stop it. Primary goal again is to slow down the ventricular response in these people so it doesn't destroy the myocardium. Yes, you will be on anticoagulation therapy. If you just have paroxysmal, you probably don't need to be on it. That's controversial. If you have persistent AFib, you have to be on anticoagulants. I expect you to know these three because your patients are going to come in with these. The old one that's been around forever is Coumadin, also known as warfarin. It's a vitamin, works on vitamin K, so you have to be careful with your diet. The Xarelto, Eliquis, and Pradaxa, those aren't vitamin K, so you don't have to have any dietary restrictions, which is wonderful. Let's do another one. 52-year-old comes in. She passed out at a basketball game. In the ER, they did an EKG after Valsalva's maneuver, slowed things down. What do you make of this? I see a lot of squiggly little lines here. Let's see if I blew one up. I did blow one up. Remember, search for the squiggly lines. Yeah, well there's, what is this? Is there like two P waves here? When you see that, or is that a T wave and a P wave? Yeah, this is not a normal rhythm. This is coarse atrial fibrillation. So these are bigger. Coarse is actually harder to see, but it doesn't make any sense. And look at the intervals. Our intervals are all over the place. There's a tiny one. There's a long one. That one's not quite as long. That one's a little longer. That's tiny again. They're all over. They're irregularly irregular. So that's coarse AFib. One-to-one conduction. Heaven forbid, what happens if your AV node is broken? You're not going to live very long. If you have 550 beats of action potentials going to your ventricles, you can't have a quivering left ventricle. It can't contract 550 beats. No blood will come out of your heart and you will not make it. So the AV node is the star of the show. Another problem is these accessory conduction pathways that can occur, because some of that fibrillatory current, or those 550 beats, what if you have another way to get into your ventricles? What if you have a hole in the fibrous skeleton? That's not good because that can spark that can drive the ventricles to go even faster. So that's not good. You're basically up the creek, right? You can't even run a long time at 220 beats per minute, let alone 300 or 400 or 500. So you'll die of hypovolemic shock because no blood is coming out. Let's look at these accessory pathways now. And this is leading up to AVRT and AVNRT. I don't know if we'll get to AVNRT. I'm going to try. So we have a rule before we get there. I should have put this in a long time ago. But the QRS complex rule. How long, what's a normal width of a QRS complex? And we don't really have to worry about it being too short because I don't know there's any case where it's too short. It's always too long. So, but the rule works good. So the 1.5 to 2.5 rule, it works perfectly against the PR interval rule. Remember, the PR interval rule was 3 by 5 little box rule. This is 1.5, 2.5 little box rule, and that's exactly one half of the PR rule, right? What's half of 3? 1.5. What's half of 5? 2.5. So that's a way you can rule it. But the duration or the width or the length of the QRS complex should never be greater than 0.10 seconds. And again, some authors use 0.12 seconds. So this is 10 little boxes. This is 12, or this is, that's 4 boxes, right? So that's 4 times 3, 12 seconds. Yeah, that's 3 little boxes. So that makes it easier. But nevertheless, we're going to use 0.10. All right, let's look at these accessory conduction pathways. So there's a bunch of AKs, of course. They're called bypass tracks, ACPs, accessory conduction pathways, bypass tracks. What are they? And so they're congenital bands of conductive tissue. So they're little fibers that skirt around the AV node. They connect the atria to the ventricles without going through the AV node. That's what they are. Those are accessory conduction pathways. They don't use the AV node. Okay, so they do not use the AV node. That's one thing they all have in common. And so let's look at some of them. So here's James fibers. James fibers run from the atria still to the atria, but they let current go past the slowdown portion of the AV node and dump it into the distal AV node, or maybe the penetrating bundles of the bundle of His. Those are James fibers. Here's a hole in the fibrous skeleton. Kent fibers live there. You can take a current, here's a current coming along. It's supposed to be heading over here. I mean, some of it is going to head over here, but some of it goes, oh look, let's go through here, and it sneaks through there. So you can get by the slowdown portion and stimulate the ventricles ahead of time. See how that works? And if you enough of those fibers, if the ventricle contracts enough, you're not going to be getting a full filling of the heart. All right, the two that I want you to know are Kent fibers. We've talked about those. Those are the ones that are in the congenital hole in the fibrous skeleton. Those are seen in patients with Wolff-Parkinson-White syndrome. James fibers, we just looked at those. Those lie next to the AV node, and they take action potentials, and they go right around the AV node. Those are seen in a second common condition called Langerhans-Levin syndrome. LGL syndrome, Langerhans-Levin syndrome. We're not going to talk about that one, though. I'm going to just focus on Wolff-Parkinson-White because that's the most common one of these conditions that's caused secondary by accessory conduction pathway. Right? So again, there's Kent fibers that are found inside here. So you need Kent fibers, but you also need a hole in the fibrous skeleton. And so that allows current to sneak in. It can also allow current to go this way. So when the ventricle is depolarizing, sometimes the current can go up that way. And then we have James fibers, which again are bypassing this slowdown portion of the AV node. Got it? Reentry tachycardia is another sequelae. Well, yeah, because now we have two pathways for electricity to loop around. It's almost like when we talked about reentry, a micro reentry circuit. Now we can develop a reentry circuit around because of these fibers. So, by the way, it's called reentrant circuit or reentry circuit. And it can result in a reentry tachycardia, or reentrant tachycardia called AVRT, which we'll look at next time. All right, but here's a sneak peek. So here's Kent fibers. So what happens if you have a current sneaking through here and it runs backwards through the bundle of His? And you get this type of a deal. You can develop a racetrack of current like that. Or the opposite way, you can get a current going this way. We'll talk about antidromic versus, antidromic AVR. We'll talk about AVRT when the time comes, which is next week. What are the symptoms with accessory conduction pathways? They're completely asymptomatic unless one of those racetrack occurrence occurs. Then you're going to have a supraventricular tachycardia called AVRT usually. Palpations, we'll talk about the collision of Wolff-Parkinson-White current with the normal current. It could be felt as a palpitation by some patients. Probably not though, because they've probably used to that their whole lives. Hypoxia would only occur if you're in the supraventricular tachycardia, which is usually AVRT. All right, what are the EKG findings with APCs? Well, if the current is sneaking into the ventricles ahead of time and the ventricles start to contract ahead of time, you're not going to have a PR segment anymore. So the PR interval is going to be short. And if the ventricles contract ahead of time, the QRS complex is going to be too long. Right? So you lose your PR segment and your QRS complex is too wide or it's too long. Because of that. Well, how wide? It's going to be wider than 2.5 little boxes, right? Or 0.10 seconds. Let's look at a case so we can help you figure this out. 35-year-old comes in for pre-employment physical. It includes EKG. He has no complaints. What do you think of this? And this ... This goes on the whole pattern. Well, he's got a slow heart rate, so it's about, that would be 300, 150, 175, 60. So like, I don't know, 58 or so. So nice, good heart rate. Maybe 35, young, maybe he's an athlete. But look at the QRS complex. It's way too wide, right? And it should 2.5 little box rule. It shouldn't be, I mean, there's 1, there's 2.5. It shouldn't be any wider than that. And it's way wider than that. That's no good. So he's got a wide QRS complex. And where's the PR segment? There's no PR segment. So this is no good. In fact, this thing has a name. That's called a delta wave. Remember that the EKG is built on straight lines. There's the R wave, the S wave is straight. Remember, we talked about slurring of these lines. This is not built with straight lines. There's one here, and then there's another one here. So that's called you could call that a slurring of the upstroke of the S wave if you wanted. You could also call it a delta wave. But this is classic in someone with Wolff-Parkinson-White syndrome. Got it? That's everything I just said. I didn't miss anything. So, all right, let's talk about Wolff-Parkinson-White syndrome, and then we're out of here. Well, I mean, we have been talking about it. It's caused by an accessory conduction pathway. So, to have Wolff-Parkinson-White syndrome, you have to have an accessory conduction pathway, or you don't have Wolff-Parkinson-White syndrome. And specifically, it's the type of the accessory conduction pathway that involves a hole in the fiber skeleton. This is not the one that has fibers that are going around the AV node. That's Langerhans-Levin syndrome. So people with Parkinson-White syndrome have a hole in the fiber skeleton, and that hole is filled with really quickly conducting fibers called Kent fibers or Kent bundles. Right? So we put them over here in this patient. So here is a hole in the fiber skeleton. Remember, this, you shouldn't have a connection between the atria and the ventricle. So there's a hole. They're filled with these green fast fibers called Kent fibers. So that's Wolff Parkinson-White syndrome. How does the current flow in a heart like this? Well, let's go look how it flows. So normally the SA node, there's Bachmann's bundle, SA node contracts and we have all these impulses heading right for the AV node. Okay, and they're spreading out through the ventricles. Some of the fibers, some of the current though has a new place to go, because usually it bounces off this wall and comes back that way. But now it's got a place to go. So some of this SA node current can go through this hole, accessory conduction pathway, this hole in the fiber skeleton, go through these Kent fibers and pop out here. So we call that, we'll call it the WPW current, Wolff Parkinson-White current, or the rebel, or the I don't know what you want to call it, the current that's not supposed to be there. Then we have our normal current coming down through here. So we have two currents, right? So what's going to happen with these two currents? This current, once it gets through the slowdown portion, this current is going to fly through the conduction system way faster than this one. This one is moving like a snail because there's no fibers, there's no bundle branches, there's no bundle of His. There's nothing for it to fly through unless it reaches here, these Purkinje fibers, these bigger Purkinje fibers. So it moves slow. And in fact, this one is so fast that they usually collide right here and they snuff each other out. Boom. Big collision right here. And both of these currents are gone. Great. And that's what happens every single heartbeat in someone with Wolff Parkinson-White syndrome. What happens if there's no collision here? I'll let you think about that till next time. All right, but there's everything I just said. So there's two pathways. There's the normal current and the Kent fibers, the Wolff Parkinson-White current, and there's everything I just drew. All right, so yeah, normally they collide, cancel each other out, and so there's no trouble. And maybe people might feel the collision. That's still debatable. That could cause palpitations, but yep, so there's the collision, everything we already talked about. What are the EKG findings in someone with Wolff Parkinson-White syndrome? We just went through them. They'll have a delta wave. They'll have a slurred R wave. They'll have a wide QRS complex. They'll have a short PR interval because they have no PR segment. They'll have a normal RR interval. Got to make note cards. This is a note card thing right here. All right, and we've already talked about this. There's the delta wave, and yep, I don't need to talk about that again. Let's do one. 44-year-old female enters your tent. Anxiety, weird feeling after a bike race. She says that her heart was racing, like her heart rate monitor showed it was going 180 beats per minute. But then it stopped, but it still feels weird, so she wants to get it checked. She comes into your tent. You run an EKG. Here's her EKG. What do you see? Well, RR intervals are good. What's the heart rate? Just kind of eyeballing it. That would be 300. It ain't 300. 150? Nah. 100 would be, so it's 80-ish, 80 to 90-ish. So it's not a tachycardia. And then there's a P wave. Great. Now the PR interval. Where's the PR interval? That's a little shaky. Now this is a drawing too. The artist she had made this a little bit smaller. but there's no PR interval, so the PR, I'm sorry, there's no PR segment, so the PR interval is short. But the key is we can calculate the width of this QR complex here, or this QRS complex. And my brain's about had it. So it starts right here. Should be no more than 2.5. 1, 2. 2.5 would be right here. So it's a little bit too long. The artist could have done a little better on this one. But another thing is, here's the thing that you can see. This is made up of two lines. There's one and there's the second. Right? So that is no good. That's a delta wave, or that's a slurring of the S wave. So what happened to this patient? She has Wolff-Parkinson-White syndrome. And after the race, she went into a tachycardia called AVRT, which we're going to talk about next time. And she snapped out of it. And now for the first time, we figured out that she has Wolff-Parkinson-White syndrome. Okay, so you can read through that. That's everything I just talked about. So you don't have to take notes on what I said. And yeah. All right, that's enough for your brains. See you guys later.